So I'm Sarah Foye. I'm the founder and president of Team Titin, and I'm here as just to help facilitate the talk today on nutrition and gastroenterology. I want to welcome and thanks all of our panelists for being here, and I would like to go ahead and just have you go through and introduce yourselves and tell us a little bit about your expertise so we can have benefit of your special knowledge today. We'll start here.
Hi, everyone. Thanks for being here, and thanks for having me on this panel. My name is Dr. Diana Bharucha-Goebel. I'm a pediatric neuromuscular neurologist, and I practice in Children's National Hospital in Washington, D.C., as well as with the team at the National Institutes of Health, with Dr. Bonneman's team. And I have been involved in the clinical care in our multidisciplinary clinics of children through adolescence and into young adulthood with neuromuscular conditions, and kind of in that whole within that kind of multidisciplinary scope, and thinking about various concepts, including growth and nutrition, which we'll be covering today, and also involved in some outcomes research and gene therapy related research. So thanks for being here.
Hi, everybody, and thank you for having me as well. My name is Mimi Girten. I am an outpatient senior dietitian at the Children's Hospital of Philadelphia. I've been at CHOP for about 20 years, been doing this for about 40, so I'm the old one of the bunch. And I have gotten the great pleasure of covering our neuromuscular clinic for a while, and in general GI at CHOP, you see everything and everyone. So this is an area of love and passion for me. I'm also our blenderized food tube feeding expert. I got that by osmosis, but I love doing blenderized tube feedings, and again, I think that's an area that's really started to grow. So I'm here to help with any questions I can answer.
My name is Laura Watne. I'm a clinical dietitian at Children's Hospital Colorado, and I've been honored to work in our multidisciplinary neuromuscular clinic for the past 14 years and work with patients from birth to young adulthood with all the different neuromuscular disorders. And I learn a lot from our families, and it's just been an honor to work with kids with neuromuscular disease.
I'm Asim Maqbool. Thank you for inviting me. I'm a pediatric gastroenterologist at CHOP. I've been there about 20 years. I have a background in nutrition and GI. I've worked in feeding, I've worked in aerodigestive, I've worked on inpatient nutrition. I do general GI now, and I have a focus on pancreatic disorders, cystic fibrosis, and international medicine currently, but I've done a bunch and I keep it plugged in with everything.
Fantastic, welcome. So I'll open with a couple of topics and questions, and then I'll open it up to the floor. The first thing I wanted to ask is about feeding tubes, and some members of our community who have difficulty with growth or nutrition ends up with a feeding tube, and families struggle with the decision of if and when to get a feeding tube, and so my question is to the group, and especially Dr. Maqbool, is what factors do you consider when advising families on this topic? And just to expand on that is, can you talk about what kinds of discussions families should be having with whom when considering a feeding tube, and kind of what questions they should be asking?
That's a good question. So there sort of are two considerations when I have as a medical provider for G-tubes. One is, can you protect your airway when you swallow? Because we have to protect the lungs. And the second is, can you meet your nutritional needs by mouth or not? Now, the conversation I have with families is when they're faltering, we try to support them as far as we can to do what's safe. And we explain that tube feeding is part of the continuum of what we do in terms of feeding. It's not a failure of oral feeding. It's part of the continuum of what we have to do to make sure that we maintain good health. Feeding is more than just nutrition. It's the pleasure of taste, of texture, of socialization, all of those things. And we do our best not to take those away from patients. So we try to do as much as we can orally, but when it comes time for the tube, we have a discussion, say this is not a failure of what you've done at home. It's a continuum of what we can do. And it is a stressful conversation. And there's a lot of guilt often attached to it, and a lot of stress. At CHOP, we're fortunate to have a family resource center where we do a lot of the education, teaching, and training for this. And then we do bring patients in, and we do place gastrostomies. And then I usually see them 2 weeks afterwards. after they've had all the teaching, the training, the inpatient kind of, if we do this on the inpatient side, reassurance supplies everything. And I'm very happy to see that wave of relief that washes over families after it's done. They're in a very different place 2 weeks before versus 2 weeks after. And then they can concentrate on not taking anything away and just augmenting everything that they were doing. So it's a difficult conversation. It's an important conversation. It's not a failure. And I think it really does help advance care.
As the neurologist, seeing these children, perhaps even before, it depends, I think different clinics might be set up where a GI physician or team may be directly part of the clinic, or oftentimes it's a referral to the GI service. We may, often do have dietitians in the multidisciplinary programs, but I think things that we look for in terms of when are we making those referrals, when do we need more help in thinking about the caloric needs for a child. So what I'm looking at usually is really those growth charts, and so oftentimes we're looking at is this child maintaining their percentile, and so if with lower muscle mass, I don't necessarily need the child to be 50th or 80th percentile. If they are steadily on a 3rd or 5th percentile, but that is where they've been, that might be okay in that particular circumstance. But if I have a child who's losing percentiles, or especially if we're not getting growth, we're not in weight, we're dropping percentiles, or if we're even more so losing weight, then we're really again quite aggressively talking about how do we supplement those calories. How long is mealtime taking? So to Dr. Maqbool's point, is it something that's fun? Is it becoming a point of stress for families where we're trying to keep them at the table longer and it's becoming 30 minutes or more and trying to get those calories in? Can we supplement with again, orally with shakes or other supplements? Can we add higher density, maybe calorie density foods and mix them in? And I know you guys can speak to that. But again, I think it's a really important point, because sometimes I've heard that that concern about, will it change the way my child gets to interact with with feeding? That's an important part of the family dynamic and socially. And again, I think it's not, as you said, I think it's a really important point. It's not taking away the feeding, it's just augmenting and supplementing so they have the caloric support, and eating can still remain enjoyable without that sort of added stress and pressure of how much you're taking orally.
Sorry.
Go ahead.
I wanted to jump in and thank you for bringing up about growth, and that this is an important issue, and a lot of people bring it up, is that our people with neuromuscular disease tend to have their own growth curve. And I think that there's a lot of stress on parents, or concern when they might be hanging out at the bottom of the growth curve. And I think that if you could speak to that, I think it's pretty common, and that to be somewhat underweight with lower muscle mass or lower bone density or lower stature, and that's okay. And like what you're talking about is staying on your curve. Like what they talked about on the exercise session, comparing yourself to yourself, kind of similar with a growth curve is comparing your growth to your curve. But if you guys can expand on that.
I'm going to go back to the tube feeding first, but I will come back to the growth charts. I think as dietitians, I often have a longer time to spend with parents too. So they'll often see GI and have that G-tube talk and come to me, but I have an hour to sit and explain it a little bit more. And it is very much a quality of life. And I think most parents feel like they're a failure. As moms, as primary caregivers, your job in the world is to feed your child. And if you can't feel your child, the first thing you feel is failure. And usually I'll get every mother in the room to cry on that one. And it's not a failure. It's actually the best thing you can do for them, because that you can spend more time. You can spend more time with your spouse and your other children, and time with them to go walk in a beautiful place like Penn's Landing. But if you're spending 2 hours trying to feed them, then you miss out on all of the time that you have with them. So I think that's an important concept. I think also realizing that it doesn't mean that you can never feed your child orally again. everybody thinks the minute you get a tube, you can't feed them orally again, and that's not the case. Often we have to do a feeding plan before they see surgery. And I tell parents, this is just a plan. We have to put something on paper. I am the most anecdotal person you will find. I do nothing scientific, so I'll lay that out there right now. So we make it work for what works for your family. This is not about me. This is about what works for your family. So I think that's a really important thing to think about. The other thing is talk to other families that have G-tubes. It seems like such a scary thing, and often I will find dads do really well speaking to other dads because they don't know, and they're only hearing what their spouse is coming home saying, and mom's doing this and dad's not listening to any of it. Sorry, guys. But that just seems to be the way. So reach out to other parents. You have an incredible support group around you, so reach out to other people. My concept on growth charts is that kids with neuromuscular disease, I plot them on a CP growth chart. The CP growth charts were designed, the newer ones, with gross motor functions in mind. They were also designed for tube-fed kids and non-tube-fed kids. So they look at them, and they don't, when you look at them on a CDC or a WHO growth chart, they end up as being round, little overweight kids. If you put them on a CP growth chart, it takes into consideration all of the other factors that go into place with neuromuscular disease. So I always put them on a CP growth chart. I always say growth charts were designed to let us look for how they grow. They can be on their own chart. I don't care where you grow as long as you're consistent and you're well nourished.
So as far as the G-tube conversation goes, I participate in those with my team members and GI providers. And we do have if you are considering a G-tube, just ask your providers to actually look at the device too. So we have an extra one in clinic where you can actually hold it, see what it feels like, inflate the balloon, and just give it a good look over. And we often have one or both parents just say they've never actually seen one, so that can be helpful. As far as growth, yes, I use the regular growth charts just to assess trends over time, and often kids with neuromuscular disease are on the low or low normal trend. But one thing I often try to predict is if I put in my notes that just a specific statement, if patients are underweight, that alerts my inpatient team ahead of time if patients are going in for surgery or something, because oftentimes the inpatient team will look at the growth curve and maybe panic a little bit. But so I try to outline that in my note for my other team members that it's okay and we have a long history of growing on our own curve. Another thing I do in clinic, if I have time, is what we call arm anthropometrics. There are standard numbers for arm measurements, so a mid-arm upper circumference combined with a tricep skin fold measurement. And often with those, I can show with actual numbers that your child's arm circumference may be normal or it might be slightly low, but we can also calculate with those numbers that their muscle mass is likely low. So I can put those numbers in the chart and alert my other team members that it's actually okay.
Hi, I'm Maria Clark. We have an 8-year-old son with Llama 2. And I had a couple statements first. To Be Friends, I think, was the organization that they actually make bears for families that have children with G-tubes. And they sent one to my non-affected child and affected child. And we were kind of thrown into this at birth. My son was transferred at a day old, and then by a month old, we had a G-tube. So we didn't really have the choice like a lot of you guys have, but I would say if you're on the fence, just do it. It's huge. It was the hardest decision we had to make, but literally that day, it was the first time that he just looked so different at even a month old. And he was actually transferred to we're from Maryland, so he was at Hopkins at birth, and then transferred to Mount Washington Pediatric Hospital, which is a rehab hospital. And by the time he left there, he was actually eating everything by mouth, and we thought, oh, we made a mistake because like he was transferred to Hopkins at birth because of feeding. But the bottom line is it's been kind of like some days he does eat a lot by mouth, and then other days he doesn't eat anything by mouth. And sicknesses, it's like a life changer to have the tube. So if you're on the fence, I'd be happy to talk to anyone that wants to have like a one-on-one conversation about it. To Be Friends was great. We gave the teddy bear to his class each year, kindergarten through second grade. We encouraged the therapist at the school to show all the kids an extension in the stuffed animal, and I just think that really helped. And something that has been frustrating for us is he started with a G-tube, and it was on the support group site for Llama 2 that we started asking questions about GJ, and we got tons of pushback from the doctors. And it wasn't until he was in the ICU one time that they're like, okay, well, maybe we'll try it. And the GJ tube has been like an even bigger change for us than even the G tube, because with the respiratory treatments, it's very hard to keep up with it when you have to run a feed over an hour and then you have to wait. And when he's sick, he needs cough assist all the time. So I can't say enough about the GJ experience. It's kept us out of the hospital so many days, where in the past he would like throw up and then end up in the hospital for weeks, where now we're at home most of the time and we might end up in the hospital for like 2-3 days, where in the past it would have been like a 2-week hospitalization. So GJ has been a game changer, and it's frustrating because I feel like there's not enough literature on that even in the CMD community. Like, we're at Hopkins, and again, we got major pushback on it. The other thing I was going to say, because he had never really eaten by mouth, we had to ask a lot of questions early on about the percentile, because he never had his own growth. And the NIH and Hopkins, we kind of came up with the agreement between the neurology and the NIH. The 25th percentile is where they'd like to see him, because they want him to have enough reserve if he ever needs a surgery to get through that. But I just want to point that out because some people don't have like a curve to look at all, like us. But my question has to do with, so predominantly he has been tube fed. He's always like, I shouldn't say always, around 2 or 3 years old, he started eating more for pleasure. And now he loves to eat, but he only has 2 teeth that line up on one side of his mouth. So he uses his tongue to mash a lot, and then he like eats with those 2 teeth that line up. And in school, as a second grader, he started learning about nutrition. And now he wants to come home and eat salads with us, because we tend to have salads more than we do like cooked vegetables. And it's hard because we have 2 typical children, and then we have Micah. And in the past, if he wanted like dessert for breakfast, I didn't care, because like he was eating a couple hundred calories the whole day. So I'm just wondering if you have any advice with like that as a whole, like typical kids with affected children, and also like how you would approach that with them since they're not eating very much. Is that the wrong approach to say you can have a cookie for breakfast?
I think there's a lot of things there. I think if he's only eating pureed things, is that the case? I think it's educating him as well on the fact that he can have different things. I remember mine. One could have cookies every night for dessert, and the other one had to have fruit. It's explaining and educating him. As far as the lettuce, I'd let him try, as long as he's safe. I think understanding that he has different needs, like we all have different needs. I think that's important, but I think there's a lot of education.
Yeah, it again comes back to quality of life and your family structure too. So if, we typically encourage structured, planned meals. So you can say, we're not having cookies for breakfast today, but you could certainly have one after lunch or after dinner or something. So to still provide that structure in the family meal experience with the same foods as the rest of the family, but still allowing him a lot of grace or the opportunity to eat the things that are safe and comfortable for him to eat.
I wonder, maybe for Dr. Maqbool, the question about the GJ or Nissen and different ages. I know this comes up actually sometimes even in the, in young babies, and in terms of, do you need to be certain, is it like a, weight related, or if someone's on BiPAP or CPAP or cough assist or other measures, how that weighs in terms of, again, Nissen or GJ versus G?
So full disclosure, I trained at Hopkins, and Kennedy Krieger, that's when I got into feeding. So as a gastroenterologist, I was always taught to do the minimal amount of intervention that gets you the effect that you want and that does not increase disability in any way. So oftentimes a gastrostomy is sufficient to meet needs that you can't get by mouth or that are not safe by mouth. But in some instances, you need to do more. So transpyloric feed, so the gastrostomy goes into the stomach. The GJ is such that you have a thinner tube that's thread through the gastrostomy into the small intestine. As you're all aware, the stomach is a reservoir. You can handle volume. You can eat infrequently. The small bowel can't handle that, so if you have to go with a longer tube, then it's a continuous drip feed. And GJ tubes are notorious for their sense of humor. The GI tract is like an accordion. It goes in and out and up and backwards and forwards, and so those tubes can migrate. They can flip into the stomach. They can clog. Sometimes they can add as lead points for intussusception or the telescoping. But they do have advantages, right? It's a safe way to use the current ostomy that you have. It's a way to feed continuously, safely. The chances of things refluxing and coming back into the stomach or, heaven forbid, up into the chest and the lungs is less. So they do have a role. Some of our patients will actually use their G-tube port for daytime feeds when they're upright and when gravity helps them. And overnight, they'll use the transpyloric or the J port as a continuous feed as a way to safely feed them. You're correct that when children get ill, oftentimes the gut will slow down even further, and the risk of what we call a post-viral gastroparesis is significant. It happens to everybody, but people who already have altered GI motility are more at risk for that. And then sometimes episodically, we'll use those longer tubes to feed if we have to. So that's there. In terms of other devices or appliances, there's something called a jejunectomy, which is like a G-tube that's placed in the small bowel directly. Theoretically, it works very well. It does work very well for certain individuals. But for others, it can cause twisting and kinking and the same telescoping or what we call volvulus, like a towel wringing, and that can be difficult. In terms of anti-reflux surgery, I only consider it when we have failed medical management, meaning that we can't manage and prevent the airway, aspiration into the airway from how we feed, what medications we use, etc. And for those of you who, I'm sure you're all familiar with fundoplication, but fundoplication, basically what happens is you wrap the base of the stomach around the esophagus. At that point where the wrapping occurs is this pacemaker for the stomach at the fundus. Now, oftentimes that pacemaker is disrupted when you do a fundoplication. And when that happens, you lose the ability to, some things happen. So the side effect profile is anywhere from 4% to 50%, and some of it is shorter term, some of it is longer term, and the experience of the surgeon matters. But you can get gas bloat because of this dysmotility, and if you have a G-tube, yes, you can vent, which is great. You can have retching because of the gas bloat, and then because the pacemaker is disrupted, you may have dumping, where things empty out of the stomach too fast. People can become cold and clammy, you can have blood sugar issues, and sometimes even with the fundoplication, you need a jejunectomy or like the J-port just for continuous feed to maintain blood sugar. So every intervention has a risk and a benefit. Fundoplication may protect the airway from reflux and aspiration from reflux, but it's not going to stop you from aspirating oral contents. So there are pros and cons to everything that we do. So the way I was trained is I was told that whether or not you believe in evolution or intelligent design, the reason that the esophagus is in the back of the chest is to hide it from our surgeons. So we try not to push for fundoplication unless we don't have any other options that work or that are workable with all of those caveats in place, okay? The other thing that you lose is something called the accommodation reflex. So if you eat a big meal and that cookie's just looking at you on the table, and you're at the stage where you say, even looking at it, I'm gaining 3 pounds, I might as well eat it. You and I have the ability for our stomachs to accommodate more volume. It's called the accommodation reflex. After fundoplication, you typically lose that accommodation reflex and you remain very volume limited. So that's another caveat. Yes, we can accentuate that with some medications like Periactin, et cetera, but there are pros and cons to everything that we do. We try to do the minimal amount to thread that needle and to get you to the safe place where you need to be. I think in the last 20 years, I've had a dozen patients who've had fundoplications, not more than that. So we try to steer away for it and do it for the right indications in the right patient.
Thank you for that input. I just want to touch on one point, which is that there are multidisciplinary centers where you can go to a feeding clinic, and it can be a whole team that includes a gastroenterologist, a neurologist, a psychologist, a nutritionist, and there are a speech therapist for evaluation, and they can be an excellent resource. They're not available in every community, but if you have access to one and you are having feeding difficulties, I highly recommend it. I see there is a question in back, but also I want to make sure that we leave time for, as we move on down the gastrointestinal track, I want to get to other topics other than feeding that are important and highly relevant for this community. So let's go to the question in the back, and then we'll okay.
I'm Rachel. My daughter is Ariella. She's 13 with NEB2 Nemelin myopathy. And I just wanted to encourage the parents, as my friend on the right said, if you're on the fence about a G or a GJ, it's not even a question. Like, I have an unaffected 10-year-old, and there are so many nights that I spend crying with him to beg him to take the medication I need him to take for whatever cold or thing that he's got going on, and I say, my God, if I could give you a G-tube right now, I would any day of the week, because I don't worry about that with Ella. Like, no matter what disgusting medication she's got to take, I just give it to her. She doesn't have to wake up in the middle of the night. Like, it brought so much peace to my home in the middle of chaos when things were really rough. So that's number one. Number two, because she also has an immune deficiency, she got sick a lot. And the fact that she would be so at risk for aspiration pneumonia, it was a nightmare when she would throw up when she was sick, and then we'd have to go NPO, and then all these things would happen, and then she would be skin and bones. So one of the things that was really helpful for us was, yes, we're all on our own curve, but we always made sure that she had reserve, because we knew when cold and flu season came, she was absolutely going to lose several pounds through that. And once we were able to get there, that was a godsend, because we would definitely spend summer packing on some pounds to get through winter. And that definitely helped her recover better. So then the question becomes, when she was little, everything was pushed towards these formulas. And I was like, well, my kid doesn't have a disorder that stops her from being able to digest or absorb. She just has the inability to chew and swallow without also choking. So how do I make sure that that she's getting what is actually best for her system when everything is a syrup-based formula that gives high density over more natural ingredients? And for a year, we blended our own diet, and then finally got insurance to cover her Nourish and her Real Food blends, and now she has the best diet I've ever seen in my life. But it made a huge difference. The year she got trached, she was still on one of those formulas, and she got RSV, she went into the hospital, and every single time they tried to start her feeds again, she would start throwing up. So on top of RSV, she had 2 pneumonias from aspiration from the reflux that was coming up while she was so sick. And that almost killed her more than the RSV did, because then she couldn't even recover from the RSV. So when we switched her over to actual food, the one that I was blending, or the blend of the Nourish and the Real Food blends, that also changed. She stopped throwing up, even when she's sick. And I think I'd like to hear if you have some insight about, is the field moving more towards or finding support for those food blends for kids that are dealing with muscle issues and not digestive or biochemical issues, so that they can be better supported. Because if I ever had to put her on one of those formulas again, I know like we'd be in trouble because her stomach won't tolerate those syrups. So I think that's another thing for us in this community. If you're not dealing with a like mitochondrial or digestive thing, that becomes part of the question too.
So blenderized tube feedings started millions and millions of years ago. So we've been doing it a long time. And then the whole wave of commercial products came on board, and I could do a whole entire lecture on that. I think blenderized tube feedings have really risen in the last probably 10 years. They really started to rise again. And it's, as dietitians, we tend to be type A, and we tend to have control issues. Totally admit it. And if you had a 5-year-old that was not affected and you're home feeding them, I would never question that. And there's a great YouTube video, and it's not appropriate for all. It's called The Very Bad Tubey RD. So watch it, it's hysterical. And it's literally about the fact that we don't have control over what you're putting in your child. If I say put 1,000 mLs of Pediasure in your child, I know you're getting 1,000 mLs. However, you could be putting 500 mLs in your child, and I don't know, because I'm not with you. So some of it is us letting go of control. I can totally admit that. But these blended products that have come on the market, there are a lot of good ones, real food blends. But there's a lot of differences between all of them that, again, seeing a good nutritionist will give you that guidance that you need. And it really just depends on what you need. I always say to parents, I'm very happy, and there are now tools. One of our surgery dietitians created a tool that literally will allow me, you, Laura, to go in and put the specific needs of a child into a program, whether they have peanut allergy, soy allergy, you want to feed your child cow's liver every day. We can put all of that in it and put the calorie level we want. We have a medical chef who put all the volumes in. So if your child is volume restricted, we can then take the volume and say, okay, I can only have 800 mLs, and we can tailor it to meet your child's needs. And that is publicly available. So let me know if you want that, because it's a great assistance. And it does secure for adequate fluid as well as sodium and vitamins and minerals. So if you need to substitute that. I always say it's nice to have some kind of a commercial product available in an emergency. You don't have, your freezer blows up. I can't tell you how many freezer doors have gone open. You go in the hospital, you lose power, it's a storm, whatever. Always have some kind of a commercial formula backup. And again, I think that real food is better tolerated by the stomach. Our bodies were taught to eat. And even if it's that you're putting 30 mLs into your child's belly, and that helps you, we make that slow transition. I usually say, again, unless the docs tell me it's an absolute no, we start slowly and we'll work on it. It's a plan, it's a future. So that's kind of my feeling on blenderized tube feeds.
Yeah, just to add on to that, there are so many nice commercially made food blended formulas now that weren't available, 5-10 years ago. So there's a lot better choices to choose from now than just Pediasure, like there was 15 years ago. But kind of along with feeding in general, to also not, the home blenderized tube feedings are amazing. I work with a few families who do that. It's a lot of work. It can be a lot of expense and just planning and preparation. So also don't beat yourself up if that feels overwhelming or intimidating to you. The commercial products we have out there are fantastic. And one thing to note too is the food-based formulas do tend to be a little bit more thick. We can put them through a feeding pump, but they need some water to thin them down. So there's other alternatives too if using bolus feeds aren't tolerated, or you're just not interested in doing that. There's thinner food-based formulas that are a little bit more user-friendly for some families. So again, it's just fun to work with different families and try to help you with your goals and what you want for your child and your family. And there's a lot more options now than there used to be, so it's great.
Okay, I know we focused a lot on feeding, and I know there's just a few additional questions, but I want to make sure that we leave time to talk about some other gastrointestinal issues, which, okay, we're going to talk about poop. And which is, it can be quite common for people with neuromuscular disease to have constipation or other bowel issues. And it's can be quite related to fullness, of how much you can eat, comfort, so many, also breathing is if you're full of stool, it can press on your breathing, your lungs for breathing. So I'm going to just ask Dr. Maqbool and all of you to speak about some reflections about that, managing bowels and constipation and medications you might use, or tips and tricks, tools for families on that note.
So the GI tract is a long neuromuscular tube, and what affects the rest of you will also affect the GI tract. And constipation is hard stool, it's infrequent stool. Full disclosure, I went into this line of work for jokes and scopes, right, as we like to say. And while poop jokes aren't my favorite, we usually strive for a solid number 2. So I think it's an important conversation, because if you don't eat enough, you don't poop enough, you don't poop enough, you don't eat enough. And when you have immobility, that can certainly add to it. So one of the things that we work very hard on is making sure that we have adequate hydration. If you're on a blenderized product, for example, yes, you have to have water. Sometimes you may have to add Pedialyte, and yes, we can give you a recipe to make your own Pedialyte at home and put them out of business together. But you want to make sure that you're adequately hydrated. You want to make sure there's adequate fiber in the diet. Fiber is very important. None of us get enough. And these fiber products you get on the market, you'd get more fiber if you ate the cardboard box than the product itself, but you do need fiber. Everybody needs fiber. And in terms of natural ingredients that you can use to help encourage the bowels to move, dates, figs, prunes can be used. You can certainly add them. We tried not to use apple juice because you take the most important part of the apple, which is the peel, and you get rid of it, and you give them sorbitol inside, and that can mess you up. So we try to push for fiber and fluids. We try to add natural ingredients to help with the bowel movements. But sometimes you need more than that. Because if you get backed up and then you don't eat and you get back, it just creates a lot of problems. So historically, we've used things like lactulose, which is a non-absorbable sugar, to help you poop. And that's usually very effective for infants. But in older children, it causes problems, because as you go up on the dose, it creates more gas and bloating and distension. And that doesn't work very well for us. There are other softeners out there. We do use Miralax quite a bit. I'd like to say a little bit of Miralax goes a long way, pun intended. But it does help soften, and then we try to get to the point where you're using just enough of a softener to make the stool soft. But sometimes a solitary agent won't do it. And with things like Miralax, I'll say, if you use too little, you may not get the effect that you want in terms of consistency. If you use too much, it blows you out. We have to get to that Goldilocks part. So sometimes you have to cut it with some fiber. And there are commercial fiber products you can use, and you can start with equal amounts or half as much to get to that Goldilocks poop, and we can use those. And then sometimes we, in addition, have to add stimulant laxatives. Senna is plant-based. We use Senna quite a bit. There are other stimulant laxatives that you can use. And then if you go 2 or 3 days without stooling, we talk about maybe using a suppository. And if you go 4 or 5 days without stooling, sometimes we do enemas. But the point is to keep things moving and going. Otherwise, it creates a lot of problems.
Thank you. Also, I know that I heard in the physical therapist talk that there are some positioning tools that you can be used to help evacuate stool that might be beneficial if you can sit on the toilet. Some of the commercial is called a squatty potty, and it basically...
So I'm going to animate this, but when you and I stand, our anus and our rectum make a right angle like this. This is why most of us can't poop standing up. When you sit on the Western toilet, the angle is more like this. Okay, and so it's not still straight. You literally have to get your knees above your waist to straighten the angle out well enough to go. And that's why the squatty potties or the steps to get your knees above your waist are so important. And you want to do active pushing at that time. So breathing techniques can help. When you blow like into a bubble wand or a pinwheel, you're pushing down on the muscles. And you want to focus your body's natural reflexes. So when you and I eat a meal, 15, 20 minutes later, we feel like we have to go usually, and that's that gastric colic reflex with peristalsis working its way through. So timing is important. Timing, positioning, the bubble wand or the pinwheel, if you're able to blow it and you do the Valsalva, may be helpful. And then I try to limit the time that you're on the toilet, right? So, usually I say the age and years you are is how many minutes you should spend in the bathroom, up to 15, okay? Historically, I'd say don't take the New York Times into the bathroom. Now I say don't take your iPhone into the bathroom. And then I have a poop playlist for my younger children, right? So depending on 3 songs or 4 songs, depending on what they're able to do. So I feel it coming, push it, let it go. And then there's a bonus track, Ain't No Mountain High Enough, if you are very productive. But you want to sort of incentivize children to go and sit and to push. And you want to make the bathroom a non-threatening place, right? Bubble wands work very well, pinwheels work well, positive incentive systems. Don't get upset with them if they can't go. Encourage them to keep trying and build on your successes. It is a process. But the problem is once you do get backed up, that rectum becomes big. And it's like an elastic waistband. The bigger it becomes, the more poop it can hold. The more poop it can hold, the bigger it becomes, and then it becomes flaccid to the point where you can't even feel when you have to defecate. And that's part of what we try to prevent. And if you get to that point, to reverse it, oftentimes people come to me and say, yeah, we used the Miralax for 2 weeks and then we stopped it. That rectum hasn't shrunk back down to size. That could take months to a year to shrink. So, and then seasonally we need to do things, right? In the summer it's hot. So summer fruits, summer vegetables are great for you, hydrating in the summer. In the wintertime, it might be chili or hot chocolate or something like warm liquids that may help you. Not the Celsius drinks, with the caffeine, but now they have vodka in them, so I would shy away from those. But there are things you can do that can help, and not everything has to be medication intensive. It's hydration, it's fiber, it's judicious use of medications for your endpoint, it's positional therapy, it's behavioral therapy. It's all of the above.
And if I can just add as well, sometimes when I'm screening as well and talking to the families about constipation, I think if there is a large stool burden as well, sometimes, a family may say, well, my kid's still stooling, but it's very small amounts and stuff. And then if we're getting an x-ray, looking at the spine or something, we see a lot of stool burden still. So we're looking at also, right, the amount of stool, the regularity, how hard it is to stool and things like that. Because sometimes they could still just have very small amounts, but there is actually still, again, when you have that enlargement of the rectum, you do have still that kind of stool burden that you're then trying to get around. So we do try to ask the right questions when we're asking about that. And
absolutely, and sometimes what you think is diarrhea is actually liquid stool flowing around a ball of stool. So it's important to do a good exam. I know nobody likes rectal exams, nobody should, but sometimes it's important to do it to see exactly, is your anus in the right place? Do you have normal relaxation? Is your rectal vault large? Do you have a rock in there that needs to be evacuated? Those things are important, and an x-ray can give you some information, but sometimes doing that exam, and again, nobody looks forward to it, it can be very helpful and important to set you on the right trajectory.
Okay, well, thank you very much for that information. We have about 10 minutes left of the session. There were 2 other points I was hoping we might be able to touch on and also see if we have remaining questions in the audience, which is, this is a super common question as people ask about in neuromuscular disease supplements. What can I take that will improve my muscle disease symptoms, and what are the downsides or risks of taking supplements? And we'd all love to take a supplement that would help with our symptoms for muscle disease. And can you address that?
Well, I think for starters, we don't have a lot of research on specific supplements and specific nutrients. So there's so many out there. So whatever you might be thinking of, to just make sure you ask your dietitian or your GI provider or primary care provider, and just bring up exactly what it is that you're interested in taking, and we can kind of help navigate whether it's safe or not, or how much you should take. I would just say in general, good balanced nutrition that provides the correct amount of calories for you and the correct amount of protein and staying hydrated. All those things have such a big impact on how you feel during the day, your GI tract, your muscle mass. So really, again, going as far as growth and strength with kids, going back to just looking at the growth chart and making sure, that each time you're coming to visit, your child is gaining weight and growing. It is really the best medicine as far as nutrition goes. And sometimes the most common supplements that you may need from a nutritional standpoint might be a multivitamin. It might be something like iron. If there's any concern with sleep or growth, we may check iron, and you might need an iron supplement. Other things we consider are bone health, so just making sure either your nutrition's providing adequate calcium, and if not, maybe taking a supplement. And then the other one would be vitamin D. That's something we may be checking annually or regularly is your vitamin D lab, and we can supplement based on your lab results for that. But really outside of those more standard vitamins and supplements, just make sure to ask your team.
No, I agree. I think I was going to say, just like vitamin D and calcium on top of multivitamin are really important. And we may, your team may be checking vitamin D levels. And we do tend to want to, if you're kind of borderline low normal in individuals with neuromuscular disease, we do want to make sure we're really optimizing that, especially if we have a situation also where there is low bone density. And that is something that we do also commonly see for various reasons in CMDs, but just in general in neuromuscular disorders for a few reasons. One may be less or no weight-bearing activity, but also even in people who are still walking or doing weight-bearing exercise or activity, just having also with weaker muscles, the interplay between the muscle and bone and that health can also impact bone density. So that is something we do, not to kind of veer onto a different tangent, but we do.
I wanted to touch on that, so that's great.
But we do, we want to monitor that. So that may be a place where with our dietitian or maybe with the bone health team, endocrinology, depending on who's part of that multidisciplinary team, we may be also recommending even higher doses of vitamin D supplementation, as a kind of first line or in addition to other measures at least for bone density management.
And I also think if you're going to supplement, make sure your supplements are safe. There are guidelines to look for safe supplements. Supplement market is not monitored by the FDA, so there's no regulations and there's no guidance. So you could be giving your child bee pollen and there's not a drop of it in there. So just be very careful, and a lot of those things can interact also with medication. So again, as Laura said, make sure that you're letting your team know. My vitamin D ploy is always go outside. I don't even care if it's winter or you live in Alaska. Please go outside. 15 minutes of unprotected sun, and I am a skin cancer queen, so 15 minutes of unprotected sun, get your child and get yourselves outside.
So we have time for one last question from the audience. If you have a burning question, you can ask for the microphone. Yes, here, if we can get a microphone here. Thanks, Joelle. And then we're going to ask the speakers to give their closing thoughts. Thank you.
Hi, my name's Melissa. My daughter is 10. She's got collagen 6 myopathy. And the question I have is about collagen supplements, because those have been big lately. And my understanding was that if you ingest them, it's kind of useless. So one, is using collagen powders helpful at all? She is ambulatory, she walks. We use a wheelchair for long distances. And I am concerned about her protein intake. So the collagen powders, like your run-of-the-mill protein powder, would that be helpful? And then the other supplement that her specialist recommended was coenzyme Q10. So what are your thoughts on those?
As far as collagen goes, it's more, I guess you can treat it more like a protein supplement, because proteins are long links of amino acids. So when you ingest it and your GI tract absorbs it, on the other side of your GI tract, it may or may not be reformed into collagen, right? It could be your body, I think, it knows which types of protein it needs. So when you ingest collagen, it gets digested. But it can count towards your total protein intake. Now, that being said, I have a brother-in-law who takes collagen who swears it's changed his life. So, again, it's all about a quality of life and just bringing it to the attention of your team. And then protein supplements, a lot of products are pretty high in protein, so especially for smaller kids or smaller people, one protein supplement can really throw off the balance of your total daily intake of carbohydrate, protein, fat. So just keeping that in mind, and again, just discussing it with your dietitian specifically related to your child about how much protein they need in a given day. So really there are protein supplements for younger kids or smaller kids. It's important to stick with pediatric products because especially the adult products for young kids can be way too much protein.
Okay, so do you guys thank you to all of you for being here today and your great information. We could keep probably talking all day. I really appreciate all your input. Do you have any closing thoughts or final thoughts you'd like to say to the group? I'll just let each of you say a few words.
Thank you for advocating for your children, and this is really a partnership with you and all of us, and continue to seek out the best evidence-based medicine you can and the best multidisciplinary teams as you can to help advance care.
Similar to what the PT said earlier, you may not have a specific neuromuscular dietitian in your local area, but all dietitians have very strict training and they're all very knowledgeable. So your local providers can still help you even if they don't have neuromuscular background, but they are always welcome to reach out, to other people in our broader neuromuscular community. One other plug I want to say that's come up in our clinic recently is we've had some patients who got G-tubes really young, either at birth or quite young, who have, and in our system, for whatever reason, sort of been lost to follow-up just to actually get the G-tube site looked at, either by GI or our pediatric. At our institution, it's the pediatric surgeons that are supposed to be looking at that once a year. So we've had some kids come back at like 18, 19, have never actually changed their G-tube appliance, and it's the wrong size, and it's creating problems. So really just have someone, either primary care or your GI provider or your surgeon who put it in, really take a good look at your G-tube, your actual G-tube button and the site once a year, just to make sure as your kiddo grows and changes that G-tube is the right size and doesn't cause problems 10 years later.
Thank you all again for being incredible advocates and having us here. I think continuing to look for resources. You're incredible parents and caregivers for your family members. Don't be afraid of G-tubes, please. They're not a bad thing. And don't be afraid to reach out to experts in the field. There's numbers and phone numbers everywhere, so thank you.
Yeah, and just similarly, I think, sometimes these take multiple discussions. It's kind of I'll call it like a work in progress, right, in terms of figuring out the right feeding, the right bowel regimens, the type of feeding, et cetera. So these are things that we always want to make sure are really kind of this, shared decision making between the clinical team and you guys who know your kids and your family and what your child needs the best, or for those who are older, yourselves and advocating for yourselves as patients. While we didn't cover too much about it, but just other things, that are really important when we're thinking about nutrition, it was covered, I think, by some of the comments too, around times of illness, having that backup plan, making sure we're keeping both enough calories, that we're maintaining appropriate sugar and so blood glucose levels during illness. So those benefits of having your reserves and having a feeding plan when you're sick, as well as perioperative management. I know we didn't really cover that too much, but making sure, and it was covered a little bit in the prior session when they were talking about scoliosis and planning for big surgeries when that comes up or if it comes up. But the importance of having kind of even really building up to not only an optimal point where you are functionally or respiratory plans, but also our nutritional status, bone health status, and then also like post-op, especially for major surgeries, things like motility plans and stuff, if there is a major surgery and maybe someone's immobilized or things like that. So the discussion not only happens when we're well, but during other particular circumstances too.
Thank you for mentioning that point. So anyway, thank you very much for your time. And it's now time for our hydration and fiber.